it's amazing how common this topic. I think that, sinusitis is not simple. I mean, I've dedicated my career to it. And I think, these questions are kind of what I would want to have covered if I were to be in a busy ER and I would want to kind of know how to manage a patient coming in acutely. So no, I think these are perfect questions. So,
Well, that should be our intro right there. Let's get to it then. So
no,
I'm here with Dr. Sam Helman, who's the man. And that's why we're wearing coats today. It's just a vibe we're going for. But we're going to talk about all things sinusitis. Let me just frame it this way, because what I want to get into is sort of like we see a lot of patients with what I believe is some form of sinusitis. The vast majority of them don't need antibiotics. They're not having like acute bacterial sinusitis. So with those patients, I'm sort of at a loss of what to do to actually make them feel better. And that's kind of where I want to get at with this conversation, but we'll work our way towards that. How does that sound?
I like it. I think that's fantastic. And I should point out that I was the one who guilted you into wearing a suit. So I do apologize for that. I thought you were looking quite dapper before, but you're even looking more dapper now.
Thank you. This is a once in a blue moon thing for me. So
yeah. So I think I think to start out, one of the first questions I think that you had posed to me was this idea of what are we looking for when we see a patient that comes in, out of the blue, with the complaint of sinus pain and pressure. I think that, like you said, I mean, you couldn't have put it, I mean, you put it perfectly it is one of the most common things that we see in the ambulatory NER setting. I think about 2 to 10% of primary care visits are sinusitis. So parsing out what is truly sinusitis and what is some other disorder, be it primary headache, allergy, odontogenic causes of facial pain and pressure, neurologic etiologies like tic-douloureux, trigeminal neuralgia. I think it can be challenging because sometimes when we think of the sinuses, it's kind of a black box. So when I'm doing a history and physical, I'm doing it with the understanding, by the way, that there is good evidence that this is how we can appropriately diagnose acute rhinosinusitis with just a thorough history and physical. And so what I'm getting from the patient is duration. I want to know how long they've had these symptoms. So acute sinusitis classically is going to be 4 weeks or less by definition. Acute rhinosinusitis is 4 weeks or less. And so I'm when I think of duration, I'm also thinking about what are the severity of symptoms throughout this duration? Is it stable? They have the same symptoms from day 1 to day 14 or day 10. Is there a change in their symptoms? Is there a worsening or a double worsening? Or are they not getting better? Are they trying medications and that's staying stable through those medications? So I care about duration. Predominantly, I care about what the symptoms are. People say they have facial pain and pressure, and then they'll point to the occiput. Or they'll say that they have facial pain and pressure. It reminds them just of their migraines. And they'll describe an aura. They'll describe light sensitivity, sound sensitivity, and you can clarify, that upon reflection that this may not be sinusitis, this may be migraine. And so the classic sinus pain is going to be over the forehead. It's going to be over the cheek. Some patients may have retroorbital discomfort. Some patients may have nasal pain and pressure. They point kind of to the midline of their nose or to the midline of their forehead. And I want to sort of characterize that pain and pressure. I want to know if they have nasal obstruction. So nasal obstruction in many is common. It's a waxing and waning process. In fact, every 2 hours, our nose varies between a parasympathetic and a sympathetic cycle from the right and left side, and patients may mistake this as being pathologic or concerning. But nasal obstruction, as can occur in rhinosinusitis, is going to be pretty noticeable. They can't breathe through their nose. They feel blocked. They feel congested. They can't get air in. And they may also notice that there's something coming out of their nose. And discolored rhinorrhea is quite common. It can be yellowish, brackish, green. It can come from the front. They may snort it out the back and notice it. And I sometimes quite inelegantly will say, do a big sniff and say, does it sound like that? Does it kind of feel like it's going back in the nose? And patients will endorse that and say, yeah, I do a deep sniff and I see this big brackish glob of stuff. And that's very characteristic of acute rhinosinusitis. I mentioned that you're trying to do tease out a cohort of things. And so in addition to ruling out primary headache, such as migraine, tension headache, which is a band across the scalp, including the forehead, I also want to ask about allergy. So many patients who have sinus disease or who have recurrent acute rhinosinusitis or have acute rhinosinusitis may also have unrelated allergic rhinitis. And so they could be having both, or they could just be having an exacerbation of their allergic rhinitis. And so I'm asking about itching of the eyes. I'm asking about itching of the nose. And those things, and sneezing, for example, and those things may point me into the direction of more of an allergy patient than an allergic, than an acute rhinosinusitis patient. So by definition, acute sinusitis, just to kind of bring things together, is 4 weeks of purulent drainage, so purulent rhinorrhea, accompanied by obstruction of the nose and facial pain and pressure. And you can have both nasal obstruction and facial pain and pressure, or you can have one or the other, but you have to have that discolored rhinorrhea.
Now, in terms of physical exam, is there anything you're doing on the exam to sort of elicit this pain or?
So that's a great question. And you know, one of the things that I was taught that I've kind of abandoned is this idea of pushing on the face. You know, unilateral facial pain and pressure is fairly characteristic of an acute bacterial sinusitis, but I don't necessarily push too much on the face as part of my exam. But I do a thorough ENT exam. I look at the ears. I see if there's an effusion. I see what's going on in the upper aerodigestive tract. Could this be a URI that's affecting everything? I'm doing a good exam of their forehead to look to see if there's any swelling, as can occur when there's an osseous complication of sinusitis. I'm looking at their eyes. I want to see mobility. I want to see if their vision is impaired, because remember, eye complications can occur with acute sinusitis as well. And so I want to make sure there's no double vision, no loss of vision, no change of color vision. I'm looking and doing an anterior rhinoscopy. I'm looking inside the nose. I'm looking at the turbinates. How swollen are they? Are there thick secretions around the nose? Is there pus that I can see easily? That can be done quite easily using a scope, or it can be done using a nasal speculum, but that can accomplish your anterior rhinoscopy. And of course, I'm looking at the mouth. I want to look at the dentition. So in a patient who has a recent dental abscess or has periodontal disease, has poor oral hygiene, you worry about odontogenic sinusitis, which can be a very aggressive form of sinusitis. I'm looking inside the mouth as part of my routine ENT exam and feeling the neck for any adenopathy. So that's my typical exam. What's beyond, I think, the scope of a regular physical exam is endoscopy. But as I said before, endoscopy, X-rays, CT scans, even lab work like ESR or CRP or procalcitonin, which are technically markers of an acute bacterial infection, all those things are not necessary to diagnose an acute rhinosinusitis.
Okay. All right. So a lot of those exam maneuvers, it sounds like you're sort of looking for other possible things. There's not a great physical exam maneuver to be like, if this is positive, it's some form of sinusitis, and you know it.
Yeah. Yeah, I think that's reasonable. Yeah.
Okay, so let's say, let's take the same patient comes in with symptoms for 3 weeks. So less than 4 weeks, what they're describing qualifies as sinusitis. Your exam is sort of consistent with that.
Mm.
Where do you go from there? How are you going to categorize what type of sinusitis they have? Or is there any utility in trying to put those patients in different types of buckets?
So that's okay. So that's a good question. So they're less than 4 weeks. So they're an acute rhinosinusitis patient. I mean, I think that the reality is that it's important for you to distinguish viral versus bacterial, but it's not always, you can't just say, oh, that physical exam finding tells me it's viral versus bacterial. I mean, for me, duration is important because a huge proportion of Americans and people around the world, in fact, I think every person in this country will have 1 to 3 URIs in the course of a year, and only about 0.5 to 2% of viral infections are going to be an acute bacterial rhinosinusitis. So the incidence of viral infections is much higher.
Right.
But what we know, and again, the evidence is not perfect. There's level C evidence that associates viral URI with acute bacterial, but there is evidence that would suggest that infections, for example, with rhinovirus or with coronavirus or with respiratory syncytial virus, that this can lead to sort of an inflammatory milieu and lead to an acute bacterial sinusitis. And so, to answer your question more directly, I think duration for me is very helpful. So if I see a patient who after about 5 days has an acute worsening or what's called a double worsening, or a patient who after 10 days, they're just not getting better. They have the same symptoms, they're just not doing well. For those patients, I think that bacteria, assuming that it's a bacterial rhinosinusitis is reasonable. Obviously we don't obtain cultures in all of our patients. I think it can be helpful to do that, but it's not always necessary to diagnose them as having an acute bacterial. Sometimes it's not practical. But to me, that's sort of how I would parse viral versus bacterial.
So you're saying when you're saying double worsening, you mean they had a URI, they were sick, those symptoms seemed to resolve, and then the sinusitis component of it flared back up again. Now you're starting to think there's a superimposed bacterial.
Exactly. And actually there was a study that was done where they inoculated patients with rhinovirus, and they found that in those patients, a number of them went on to have acute bacterial sinusitis. So it's statistically significant number of them went on to have sinusitis. And so, it would suggest that these viruses are just kind of creating a pro-inflammatory environment. Maybe they're blocking the osteometal complexes through inflammation and edema, and it just leads to a situation where a bacteria can sort of take advantage of that.
So let's just go over again the criteria that you're going to use to start antibiotics.
Okay, so in a patient who has acute uncomplicated rhinosinusitis, typically they are coming to me already after they've tried some form of therapy. They're at that 10-day, 2-week mark. They're miserable. It's reasonable to give them an antibiotic, and I tend to give Augmentin. I think there's a lot of penicillinase or penicillin resistance out there. I think it's reasonable to give Augmentin to these patients, and so for them, I'm willing to give antibiotic therapy. If there's any suggestion of a complicated rhinosinusitis, for sure, I'm thinking about giving antibiotic therapy. In fact, sometimes you even want to think about giving them IV therapy, and these are patients who are having orbital complications such as preseptal, postseptal, or orbital cellulitis, subperiosteal abscess, or orbital abscess, or in very rare but dreaded cases, cavernous sinus thrombosis. So for those patients, for sure, you're thinking about giving antibiotics. I also will give antibiotics if there's any osseous complications. So these are patients with the classic Pott's puffy tumor. Patients who are having swelling of the forehead, bony degradation that can be seen on CT. These are patients with acute bacterial that kind of just went awry, or with malar abscesses, things of that nature. So if it's causing something beyond the sinus, I'm thinking antibiotics for them too.
So take an uncomplicated case of sinusitis where you don't think there's any orbital or dental complications or maxillary complications, and they've been having consistent symptoms for 10 days, 2 weeks, have tried things, it's not working. You may consider giving them antibiotics, plus or minus them having a fever. They may be afebrile with you, but you're still going to consider giving them antibiotics.
Yeah, I'm still going to consider giving them antibiotics in that case. Absolutely. The double worsening after 5 days, 10 days or more of symptoms, absolutely. In fact, if you look at the middle meatal swabs of patients, with an acute rhinosinusitis, you'll find H. influenza, you'll find Moraxilla catarrhalis, you'll find penicillin-resistant pneumococcus, all these things, and it makes sense that you want to give them Augmentin. So I think antibiotics, and I typically give a 10-day course, is very reasonable in these patients. And sometimes what I'll do if I have a reasonable patient who comes to me before that time period, I say, well, look, I trust you. I'll write you a script. Don't fill it unless you have, continuation of these symptoms. And my patients are typically pretty good about that. And one thing I should mention, by the way, because this always comes up, is if they're penicillin allergic, you can give Bactrim. You can give Doxy. I tend to give Doxy a fair amount. I would warn patients with doxycycline that they could have a reaction or rash if they go in the sun. I've seen it in one patient, but I believe it now, and I think it actually does happen. Or you can give a fluoroquinolone. Obviously, if you're going to give a fluoroquinolone, I would recommend against giving them a steroid at the same time and not have them go on long runs. You worry about their tendons and joints. But that's not the only thing I'm giving them. I tend to throw the book at them, and that we have good data. In one of our larger publications, we sort of did a consensus statement of how we treat acute and subacute and chronic sinusitis and recurrent acute sinusitis, and we delineated what we feel is a standard of care for patients with this disease. And there's a whole host of different adjunctive medications you can give in addition to the antibiotics. So, and one of them is intranasal steroids. There's grade A evidence for intranasal steroids. I think that it is very helpful even as a monotherapy in mild or moderate cases, and I give it as an adjunct in severe cases because I really do sincerely believe that it shortens recovery, and we have data that demonstrates that as well. I think systemic steroids, that's one of the second most common questions I get from my ER colleagues. Systemic steroids, there's not great evidence. It's grade D evidence. They have pretty minimal, in my mind, benefit. I think that it can be helpful in some of very severe symptoms, but I don't always recommend it. I give it if someone has really excruciating headache or really bad facial pain. Other than that, I don't tend to give systemic steroids. I think that
intranasal is Flonase sort of your go-to.
Flonase is my go-to, but it runs the gamut. And even the way you provide it can run the gamut. I mean, for many, for example, my chronic sinusitis patients, I give budesonide respules that come in a little vial. They crack it open, they put it into 8 ounces of salt water, and they use it in their neti pot. But yeah, Flonase, budesonide, Nasacort, all those things can be quite helpful. Taking care of this, yeah.
So nasal steroids, yes. Oral steroids, no.
Mm-hmm.
What else?
So high volume nasal rinses. I don't know if this is advertising. I'm not associated with this company. I wish I was. If they want to send me anything, Sam Helman MD, I can give you my address later. But neti pot.
Neil Med saved me so many times in my life.
Yeah, I think it's great. I'm going to open it up. I mean, it comes. Oh, this one only comes with 1 packet. But these are cheap. These are the bottles. It gives you a line to fill it up to, and you lean forward, you shoot this into your nose. There's really right hand for right side, left hand for left side. There's minimal harm that you can do. I say that not knowing if one day I'll find someone who does harm with this thing, but I mean, it's a safe way to provide nasal saline to edematous and inflamed sinuses that could really use a little bit of a topical mucolytic in the form of saline. But I highly recommend that. I don't recommend necessarily low volume rinses, the 10 cc sprays or things of that nature. I think it should be high volume if it's going to have a benefit for patients.
It's almost like gargling for your nasal cavity.
It's like gargling for your nasal cavity. I mean, some patients don't love it, and I've used it myself, and it can feel a little bit. I've had patients describe it on a spectrum. On one side of the spectrum, it's no problems at all. In the middle, it's maybe some ear fullness, some ear discomfort. On the other side, I've had patients stop it because they say it feels like drowning. I would say that the overwhelming majority of patients tolerate it very well. It does feel a little bit strange at first. There's a whole host of literature online. There are great videos on YouTube that show you how to use this, and it really does the job. It really does help quite a bit. I would recommend, however, replacing it about as much as you do your toothbrush. So make sure that you're not using it, the same one all the time.
Crusty old bottle.
Yeah, exactly.
So are you going to have people do this once a day, twice a day, or?
I would do it twice a day. I think if the stated goal is to improve that nasal patency, improve that rhinorrhea, get that post-nasal drip under control, you really should commit yourself to 2 times a day, not just 1.
Okay. All right. So nasal steroids, nasal rinse, anything else that you like to give?
Yeah, I mean, so it's not that necessarily that I like to give these medications, but I mention them because these come up so often. And I think, I will sometimes, for example, give a nasal decongestant. It's not common, and that includes Afrin. I mean, the feared issue with Afrin is causing rhinitis medicamentosa. It's quite addictive. You have that instant relief if you're going to use it, no more than 3 days. But there's only really levels to the evidence that it does anything to your disease course. So if someone, for example, says, "Look, I have this big meeting. I'm doing this podcast about sinuses with Avir. I need to get better." Sure, you can spray your nose with some Afrin, and you can get that, maybe a modicum of relief. But I don't always recommend it. I don't always recommend oral decongestants. I think sometimes it can cause insomnia in patients, and really getting a good night's sleep, resting, getting healed is important. And if you're on some of those oral decongestants, it's sometimes hard to do that.
So you're talking about pseudoephedrine.
Yeah. Yeah, I mean, I
don't-
find that it makes patients irritable. When I've used it, it causes palpitations. I don't necessarily love it. I don't think there's great evidence behind it. Antihistamines. So antihistamines, in my mind, are an option if you have allergic rhinitis. I think that there's not great evidence for the association necessarily between allergic rhinitis and acute rhinosinusitis. But I do say that if you have it, if you have allergic rhinitis, it's reasonable to take it as an adjunct. And then the other thing I always get asked about is things like acetylcysteine, which is a mucolytic. I don't recommend acetylcysteine. I think that if you're going to be diligent about nasal rinses, that's really acting like a mucolytic for you. So I really don't recommend it necessarily. And there's one study, if I recall, that didn't really show any benefit radiographically when using acetylcysteine. So.
Okay, so just to sort of summarize this, if we see someone with acute sinusitis, that means less than 4 weeks of symptoms, everyone is going to be at least offered, nasal steroids, generally speaking, nasal steroids, sinus rinse. You may add on a antihistamine if you believe there's an allergic component to it.
Decongestants.
Oh yeah, decongestants with caution. The Afrin you can use for 3 days, but then you just start rebounding and it gets worse. And we talked about pseudoephedrine if they want it. And then if they have like a double worsening of symptoms or symptoms lasting for more than 10 days, you're going to add on augmentin onto that.
Yeah, exactly. If they are not penicillin allergic, I like to use augmentin because of the incidence of penicillinase and penicillin resistance. Absolutely. And you may get patients who come to you who are patients with recurrent acute sinusitis. So they've had 4 episodes a year, or sometimes the criteria is 5, just to reduce the likelihood of us, bringing them to the operating room. These are patients who have multiple infections with nothing in between. And they may have benefited perfectly from a different antibiotic. And so I think it's helpful to ask those patients, or you may get a patient with chronic sinusitis having an acute worsening of their chronic sinusitis. These are patients with 12 weeks or more of sinusitis symptoms, plus other defining criteria. But my point, though, is that it can be helpful in those patients to see what they've used before, see if they've been cultured, and I give whatever antibiotic has either worked for them, or then I revert to my norm, or whatever I give typically.
Great. No, this is awesome. I think what I want us to be able to manage is those first 4 weeks, because the majority of patients we see do have symptoms for less than 4 weeks. And you talking about some of these medications, a sinus rinse, I think is super helpful for us to be able to give patients when they're having these symptoms.
Yeah, I think that's great. I mean, I think really from the sinus standpoint, the things that are the most critical is that you're diagnosing, the acute rhinosinusitis. You know sort of what to do on the history and physical. That's all you really need in terms of being able to make that diagnosis. And then of course, that you know what to look for as a complication of acute sinusitis. So we mentioned those orbital complications, which can be quite severe. So I'm always asking about, do they have any mental status change? Do they have any altered sensorium? Is there any clear drainage maybe coming from their nose? Maybe this was a sinus patient who had surgery, and then they have clear rhinorrhea, and you think, could this be another sinusitis? Well, it could also potentially be a complication of a procedure, such as brain fluid leakage, CSF rhinorrhea. I ask about things like neck stiffness, signs of meningitis or encephalitis. And I think being aware of those acute complications, like I said about the orbital complications, intracranial complications such as epidural abscess, subdural empyemas, brain abscesses, and then finally those osseous complications, the Pott's puffy tumor that I mentioned. All those things should be on the differential as well. But those are rare. Those are 1 in maybe 90 to 100,000 of patients with acute rhinosinusitis will have a very serious sequelae of their sinusitis such as that.
Excellent. This is great. Anything you want to add?
Well, actually, no, I do have something I want to add. I want to
Yes.
mention my sincere appreciation for what you guys do. My wife is a ER doc. I think she's the best doc I know, and maybe I'm biased, but I really think that I think that it's a tough job, and I think that this podcast is great because, you know, having this conversation kind of, you know, trying to put things, you know, on a how we think of it, and how what we would look for if I was in the ER. I think is helpful, is what I would want to know if I, you know, wanted your advice on something that came through the emergency room that I had to take care of, you know, that. So I think that it's really good that we're able to put things, you know, in this YouTube video, and disseminate it to the crowd. So,
Well, Sam, we'll have to do another one, and next time I'll wear a tie. It'll be great.
no problem, man. That sounds great.